Acetaminophen toxicity. Acetaminophen is one of the most commonly used oral analgesics and antipyretics. It has an excellent safety profile when administered in proper therapeutic doses, but hepatotoxicity can occur after overdose or when misused in at-risk populations. Acetaminophen metabolism occurs primarily in the liver. Most patients who overdose on acetaminophen will initially be asymptomatic, as clinical symptoms of end-organ toxicity do not manifest until 24-48 hours after an acute ingestion. Therefore, to identify a patient who may be at risk of hepatotoxicity, the clinician should determine the time of ingestion, the quantity, and the formulation of acetaminophen ingested. The clinical course of acetaminophen toxicity is divided into 4 phases. Physical findings may vary, depending on the degree of hepatotoxicity. Phase 1 occurs 30 minutes to 24 hours after ingestion. Patients may be asymptomatic or report anorexia, nausea or vomiting, and malaise. Physical examination may reveal pallor, diaphoresis, malaise, and fatigue. Phase 2 occurs 18 to 72 hours after ingestion. Patients develop right upper quadrant abdominal pain, anorexia, nausea, and vomiting. Right upper quadrant tenderness may be present. Tachycardia and hypertension may indicate volume losses. Some patients may report decreased urinary output. Phase 3, it is called hepatic phase, occurs 72 to 96 hours after ingestion. Patients have continued nausea and vomiting, abdominal pain, and a tender hepatic edge. Hepatic necrosis and dysfunction may manifest as jaundice, coagulopathy, hyperglycemia, and hepatic encephalopathy. Acute kidney injury develops in some critically ill patients. Death from multi-organ failure may occur. Phase 4, we call it recovery phase, occurs 4 days to 3 weeks after ingestion. Patients who survive critical illness in phase 3 have complete resolution of symptoms and complete resolution of organ failure. The serum acetaminophen concentration is the basis for diagnosis and treatment. A diagnostic serum concentration is helpful, even in the absence of clinical symptoms, because clinical symptoms are delayed. The Rumack-Matthew nomogram interprets the acetaminophen concentration in relation to time after ingestion, and is predictive of possible hepatotoxicity after single, acute ingestions of acetaminophen. Rumack-Matthew nomogram, used to interpret plasma acetaminophen values to assess hepatotoxicity risk after a single, acute ingestion. Gastrointestinal decontamination agents can be used in the emergency setting during the immediate post-ingestion time frame. Administer activated charcoal if the patient is alert and presents, ideally, within 1 hour post-ingestion. This time frame can be extended if the patient has ingested an acetaminophen-based sustained-release medication or if the ingestion includes agents that are known to slow gastric emptying. Patients with acetaminophen concentrations below the possible line for hepatotoxicity on the Rumack-Matthew nomogram may be discharged home after they are medically cleared. Admit patients with acetaminophen concentration above the possible line on the Rumack-Matthew nomogram for treatment with N-acetylcysteine. N-acetylcysteine is nearly 100% hepatoprotective when it is given within 8 hours after an acute acetaminophen ingestion, but can be beneficial in patients who present more than 24 hours after ingestion. N-acetylcysteine is approved for both oral and IV administration. The IV formulation of N-acetylcysteine is commonly used in many institutions for the treatment of acetaminophen ingestion. Use of the IV formulation of N-acetylcysteine is preferred in the following situations: altered mental status, GI bleeding and/or obstruction, a history of caustic ingestion, potential toxicity in a pregnant woman, Inability to tolerate oral NAC because of emesis, refractory to proper use of antiemetics. Surgical evaluation for possible liver transplantation is indicated for patients who have severe hepatotoxicity and potential to progress to hepatic failure. Criteria for liver transplantation include the following: metabolic acidosis, persistent after fluid resuscitation, renal failure, coagulopathy.